Thanks so much and welcome back. Welcome to this session on health systems. Obviously, if you're going to really reap a longevity dividend, you need to invest in the health and ensure healthy longevity. And when the Commission met and also held a workshop in Singapore with John Wong as host, we looked at this in considerable detail. And one of the things that really struck people was how population ageing is not occurring in isolation. There are multiple other trends which are occurring at the same time. Just as you have a demographic shift to older populations, we're having an epidemiologic shift to chronic disease. People these days are the biggest drivers of morbidity and mortality aren't acute conditions or injury, it's chronic disease. And we need to think about the impact of that transition in terms of the healthcare we deliver, because most of our health services are designed to respond to individual acute conditions, identify them, treat them, cure them, and say goodbye. But chronic conditions need to be managed in an ongoing way. And often chronic conditions occur at the same time in multimorbidity. So there are often complex clinical decisions. And so our health systems really need to shift their focus towards delivering that sort of care. Chronic conditions are also sometimes preventable or at least delayable. And so that means we need to have a much bigger focus on preventive care. So this transition to chronic disease is really a significant one as we're thinking about healthy longevity. Another transition that's happening, and it just seems to be happening with increasing speed, is technological change. Not only are we having new devices every day, it seems, but also we're having new ways of collecting data, and now large amounts of data, which allow us to actually look in very different ways at the individual. In the past, we've tended to look at health from the perspective of the absence of disease. If somebody doesn't have a disease, we tend to think they're healthy. All of this new data, all of this new information allows us to think much more about what's happening underneath, what's happening before people develop disease. And there's a field called geroscience which has been developing, which is really exploring those changes. And so the Commission also tried to think about the implications of those initiatives. There's also dramatic social changes which are occurring, and we heard this morning Victor Zhao was talking about the dramatic family changes which are happening. Women in most parts of the world these days have very different aspirations than they may have had a generation ago, where the expectation was that women provided care. So as you're looking to provide long-term care for older people, we have to think beyond, well, here people do it differently, family look after older people. It's not sustainable anymore. So in terms of coming up with the roadmap for healthy longevity, the Commission really had to take account of these quite stark underlying social shifts. And in the recommendations in terms of health systems, we identified three key areas. The first one was we need to invest much more in prevention, in public health, in population health, population initiatives which can help people maintain good health rather than treat poor health when it arises. Secondly, we need to redesign our health systems so that they provide much more integrated, personalised and person-centred care. Instead of the silos of healthcare we have at the moment, where people present with a condition to one clinician, then they present with another condition, a condition to another clinician, and there's no connection between them. We need an integration and more holistic approach to our healthcare. And thirdly, we need to develop systems of long-term care. And there's not many places in the world where we really have effective systems of long-term care. And we need to think about what that means. And when I talk about long-term care, I don't just mean institutionalised care. I mean providing care and support for people as they age in their homes where they generally want to continue to live. So we have a fantastic panel today to discuss some of these issues. I thought I would just start by trying to get a general response from each of our panelists to those ideas, to the ideas of a greater focus on public health, a reframing of the health system towards integrated care, and the development of long-term care systems. So Dr. Alfada, I'll pass to you first.
Okay, thank you very much. Actually, as you clearly mentioned, the healthcare system, which is currently is not matching well our plan to have a healthy longevity healthcare. The healthy longevity healthcare systems usually depend on prevention of diseases. It depends on having affordable and accessible healthcare, because if you want to talk about prevention, then you need to make sure that everybody in the society will have access to this prevention services. And also it's important that we utilize the data that we have in predicting what could be the consequences of certain risk factors on the diagnosis of diseases. So not everybody that would have certain risk factor will progress very rapidly to have a disease. So these three items, the prevention and the affordability, accessibility, and the prediction models is very important, I think, in the healthy longevity healthcare system. The second important point is that when we talk about prevention, we don't just focus on primary preventions, preventing diseases itself, but also when a person is affected by a chronic disease, they could have another complication added to it, and what we call the secondary prevention is very important. So I give you an example that we've been suffering from worldwide for years and years is the obesity epidemic that we are having. And I choose obesity because there is a parallel increase of the prevalence of obesity with the increase in the life expectancy. We know that obesity would affect the function of a person, the life expectancy of a person, and this is going to affect our older population as well. What happened is that obesity has been considered to be a behavioral phenomenon, is that somebody who's eating more and working less or exercising less would have just to happen to have an overweight or increase in his or her body weight. And this has been neglected for years and years, and then all the complication would happen after certain amount of years, and then the healthcare system will have to suffer with these complications. If we want to tackle any population, I think a chronic disease should be tackled as quickly as possible, not only to prevent the disease from happening, but also to prevent the complications. So what we see, for example, in obesity is that people are being followed in the healthcare system for years and years, and nobody discusses with the person their weight and the consequences of the weight, and what could happen if they just continue without doing anything about it. And there is a big gap even in the knowledge about this, because if you ask even healthcare professionals about obesity, they think it's only a behavioral phenomenon. It's not a chronic relapsing disease that need to be treated. So this generated a gap between the healthcare services and the patients or people or population in terms even of discussing this problem. So we have missed a lot of opportunities in acting quickly. And when this happened, so if you ask your patients about help in this area, then you don't know exactly where to go. So the healthcare system was not supporting to continue this care to a second or third level to help this population. So I think the lesson from here is that we need to talk about prevention in all aspects, preventing the disease from the beginning, preventing the complication of a disease, and having a system that have all this together to promote the health of the population.
I think that's a really important point, because when I hear people talk about prevention, they always tend to focus on, and chronic disease, they always tend to focus on the prevention of NCDs, but we have to be thinking about the consequences and trying to prevent the declines that are associated with aging as well. That's a terrific point. Dr. Al-Kharidi.
So this is a really interesting question, and the way you look at it actually is basically when it comes to healthy longevity, you need to look at the whole span of the spectrum. So living well, living with the disease, living with frailty, as well as also living in terms of like complex and crisis kind of management, and eventually living in a healthy longevity spectrum and dying with dignity. So that's how you look at it. Most of the goals has to be directed to this whole spectrum from my perspective. I also think that there is a lot of factors that lies outside the healthcare system. So there are several basically social determinants of health that affects healthy longevity. We understand that basically about maybe 40% of these factors are behavioral factors. If we actually tackle them proactively, they can maybe get quantified as around 10 years of extra life if possibly addressed in the appropriate manner. There is also other factors when it comes to the social determinants of health, such as education. So education either for the people that are providing the care, but more importantly, the older adults themselves. So when it comes to education, we understand that education can potentially save up to 30% of premature death and mortality. So we need to focus also at addressing these factors. So other than that, the stability of the economic systems that will definitely can translate into real gains when it comes to either the healthcare system or the social system. The other thing is you mentioned also that care has to be designed for people at all stages and in the right place in the right time. So healthy longevity will differ from country to country. So we need to involve also the older adults in that dialogue. Like we have to ask them how they want to retire, how they want to, what's the right place for them to receive care, and basically scale up these areas to fulfill their goals and requirements. Throughout the years, I've heard different terms to describe the same maybe concept. We talked about earlier on, we were talking about successful aging, we talked about active aging, and now we're talking about healthy longevity. They all basically come to the same main concepts. So it's basically providing the right care, right quality of care across the span of patient's journey of life. And so when it comes to our system, we really need to first engage people, engage policymakers to understand how we want to scale up our system to address the 8 goals that were mentioned earlier.
Can I ask, when you say receive care in the best place, I know that you're responsible for healthcare in the home. Is the home the best place to get healthcare? Or, I mean, I think what the Commission identified was we need to shift very much from tertiary care through to primary care. But are there really innovative ways which we didn't consider that we should have?
Honestly, so we really look at it from a different perspective. So we want to reach the highest quality delivered by the best practices for the right people in the right time, and the home care can reach that triple aim, so of value, quality, and safety of care, also maintaining the cost of services. So we need to consider all these factors. So we do think that home care is one of the innovative ways, basically engaging with older adults in Saudi Arabia. They prefer to be treated at home. COVID-19 actually gave us a great opportunity to bring innovative solutions. So here in the Ministry of Health, we started in partnership with multiple players to start the first hospital-at-home program in the Ministry of Health. It was a great opportunity for us to deliver acute care services at home. The other thing is we're also focusing on preventive and scaling up the service. So just this year, we, through communication with decision makers, we introduced 3 different streams, such as palliative care, home hemodialysis, and other types to enlarge our scope. And from the experience, we see that experience, like basically ourselves here in Saudi and the world, they provide quality care as well as saving costs. So we think it is more sustainable, and we think that these type of innovative solutions will definitely help us address the healthy longevity in Saudi. So thank you so much.
Dr. Al-Shankiti.
Yes, thank you very much. This is a very, I think, very important discussion, and I think, if we start with the massive transitions you mentioned, epidemiological, demographic, social, technological, these are significant changes that are happening that would necessitate significant changes in healthcare systems to respond to these changes. And the changes required are no less than a complete overhaul of many of the many components of the healthcare systems as we know them. It's almost flipping the healthcare system on its head to be able to respond to these challenges in a meaningful way. Our healthcare systems in the majority of the world are built on a chassis of acute care as opposed to care to chronic diseases. And we have a tsunami of non-communicable diseases that is hitting many of the countries across the world. And responding to that requires significant and serious changes that are scalable and also sustainable. Luckily, we have lots of insights and lots of evidence suggesting what needs to be done. Institute of Medicine, the Crossing the Quality Chasm, for instance, outlined really how systems need to change to respond to many of these issues. And it's not just about the elderly care and healthy longevity, but also it's across the lifespan of people. So I think the task is massive, it's complex, but the roadmap in terms of what needs to be done is clear. I think if you look at the Institute of Medicine Crossing the Quality Chasm, there are certain fundamentals that have proven to be effective and important for systems to adopt, be it being proactive and looking at prevention, looking at integration of care, being person-centered, and responding to the cares of people, as persons. And then looking at the system as a complex adaptive system, that you need to understand the rules of these systems and manage them as complex adaptive systems. In Saudi Arabia, and I think in many of the countries in the region, we have, I think, a historical opportunity to deal with these issues and to fundamentally restructure our systems to be able to respond to these massive transitions that you mentioned. We started with looking at models of care and how we design models of care for the future to be able to respond to persons' needs and these transitions. We looked at how care delivery should be structured in an integrated, patient-centered or person-centered ways. We looked at healthcare financing and how can we create the right incentives for people to aim for outcomes that matter to patients and be responsible for patient outcomes that matter to patients and be the right stewards for healthcare resources that we have. We looked at the policy aspect of things and how we can work beyond the healthcare system as such and integrate with other components of the society in a whole of society approach, be it within health policy aspect on the governmental side, but also interacting with the non-for-profit entities and NGOs and the society at large. We looked at how we basically incentivize the private sector to contribute and do what they're best at in terms of bringing capital and being efficient in deploying it. And also we looked at the importance of research, development, and innovation. And I think probably the most important thing that we have in this region is the massive political will to create meaningful and sustainable change. And this is a fundamental requirement for any significant healthcare system reform.
That's terrific to hear. And I think the important thing is a lot of countries seem to be waiting till they get old before they take action. And I think the time to act is before the country gets old. That's when you can put in place the sustainable systems that can have lasting benefit. Dr. Hashmi.
Well, thank you, John. Yeah, I have not much to add for the general concepts of what the panelists have already mentioned. But the themes that we hear again and again is healthy living, longevity, and sustainability. So I agree with all the concepts that have been put forward. I'm just going to give two specific examples, what it actually means, where we should be and what this conference, where we have policymakers, scientists, and many other disciplines together. One of them is food industry. We talk about healthy living and foods. It's been a long time since the IARC, which is the International Agency for Research in Cancer, WHO's agency in Lyon, put forward the class 1 carcinogen, which one of them was smoking, but other was processed meat, processed beef. What have we done actually? Public doesn't even know actually that like smoking with lung cancer, this is a 100% risk factor proven as a class 1, not class 2 or 3, class 1 carcinogen. To actually put down, or actually at least make the public aware that the fast food restaurants, which have processed meat, not fresh, the implications of that to colon cancer, which is expensive disease. So this is an example, cereals and type 1 diabetes risk, not type 2 I'm talking about, type 2 as well. And the relationships and the odds ratios and hazard ratios of epidemiological studies that we've seen are significant. But how much action has been taken at policy level for that in food industry, both in US and outside US, is minimal. Because if you ask even endocrinologists, I ask a lot of times, tell me the papers that we, of the cereals and the link with type 1 diabetes and antibodies and all those things, a lot of people have no idea. Because of public health epidemiology, knowledge is pretty poor. It's not taught actually in medical schools too much anymore. The second example is a funny contradiction of some countries. For example, Finland has one of the highest happiness index in the world. But on the other hand, if you look at some Scandinavian countries, they also have one of the highest social isolation and loneliness index as well. And we know that in some papers, the risk of cognitive dysfunction, which is an aging-related disease like dementia, leads to dementia, is up to 30 to 50% in some studies. So what have we done as a group in this country, in Europe, in Australia, in US and Canada, Brazil, to actually combat at a systemic level, at policy level, social isolation and loneliness in all age groups, let alone the elderly, which is going to prevent a lot of diseases, actually, if you tackle that. So those are two very specific point examples that I'm trying to give, that what it means in real world, and the real world challenges of this. Thank you.
Excellent examples. And I'd like to come back to a couple of the issues that they raise in a moment. But first, Dr. Wong.
Well, thanks, John. And again, I think the panel has put it forth very clearly that health systems need to move from being reactive to proactive, because if we remain reactive healthcare systems, we will just not be able to deal with the huge amount of chronic disease, which will be coming upon us if populations, as they age, if they are not healthy. So I think it's always useful to go back to definitions, and if we remind ourselves that the WHO definition of health is a complete state of physical, mental, and social well-being, and not just the absence of disease, then I think that certainly this morning we heard why this is so important. The roadmap, the global roadmap, actually is a great step forward. It tells us what we need to do. The big elephant in the room is, okay, how do we do it? So certainly in Singapore and the healthcare system that I'm involved in, we've actually decided to take one township which is representative of Singapore in 2030, both in terms of demographics as well as socioeconomic profile. It's 100,000 people, 22% are already over 65, 80% live in public housing. And we're asking ourselves, well, how do we get all the actors that Dr. Freed showed on her slide, how do we get all the actors together to actually try and address a life course where we can invest in really trying to ensure that people remain as healthy, physical, mental, and social well-being for as long as they can through their life. How do we give people a sense of meaning and purpose throughout their life and not just in the first 60 years of their lives? How do we strengthen intergenerational cohesion? And then how do we allow people to age in place so that if they do choose to want to die at home with comfort and dignity and safety, how do we enable that? So I think the big push that we need as members, as key leaders of society, is to really ensure that all our populations can benefit from what science has shown us. And I think, as John and Dr. Victor Chow have mentioned, this is the time we need to do this. There is no time which is too early, because the complexity of the issue is so profound that it really requires us to actually read the report, digest the report, bring it back to our own societies and say, okay, how can we implement it?
Okay, I'm really glad you gave the example of Singapore, because they are doing terrific work there. I've been involved with them. It's great to see. We're going to run out of time, but I want to, before we finish, look at some of the issues that people have raised, particularly how do we get the incentives in place which will drive the sort of change which we want to see. Now, Dr. Hashmi, I know you're an interesting person personally. I mean, you are a specialist in public health, but also you actually practice hematological medicine and cost the health system a fortune. How do we actually get the health system to shift that investment so that there's more focus on what you were saying before about public health?
Thank you, John. That's a great question. In fact, some of the therapies that I do, CAR T cells and the gene therapy coming up, are millions of dollars per infusion of gene therapy per patient. But if you incentivize the people of different types of incentives, financial, non-financial, rewarding, that the investment in public health is necessary, is critical for all of us as a group, as a country, as a nation, and as a world. I think that would be the key. Unfortunately, the public health funding in many countries on earth has fallen down over the past few decades with the rise of the corporate culture. So how do you bring back the corporate culture, the private equity people, venture capitalists, firms, the governmental agencies, for example, NIH, to invest more, not in treatment, precision medicine, and developing million-dollar drugs, but actually in public health measures, which were really one of the top priorities of research just 100 years ago in England, where a lot of scientists would get together, and that was the cream and supreme scientific community. And they were getting a lot of push from the government and a lot of funding. But our funding is less than 10% in pure public health non-vaccine research at the moment, compared to billions of dollars, hundreds of billions, just being spent just on developing special immunotherapies and cell therapies for cancer.
One of the things we actually raised in the roadmap was the idea of precision public health, that all the big data which is now being collected by wearables and in other ways should enable us to actually target our public health initiatives more effectively. But Dr. Al-Shankiti, we were talking outside a little bit about incentives and disincentives, and I'm wondering, from an economist's perspective, what are the things we can put in place which will have a lasting impact and start steering the system towards the sorts of outcomes we're talking about?
Right. I think the mismatch between financing and impact has been a major problem with many healthcare systems, and that there's now the shift towards linking financing to health outcomes that matter to patients. People call value-based healthcare. I think that's a fundamental shift that needs to take place in many healthcare systems, in which we say we need to reward outcomes that matter to patients more than rewarding activity and volume as such. And that requires a significant change in the way healthcare delivery is organized to allow for these healthcare delivery systems to respond to incentives like that. So integrating care delivery teams, having the right digital infrastructure to allow them to really monitor how their services are impacting people, reaching out and engaging patients and having them really voice the way they see the system is responding to them or not responding to them, measuring the quality of life and other ways of evaluating the impact of care services. So I think it's a huge mindset shift that requires significant changes in how delivery systems are organized and orchestrated that also require significant infrastructure in terms of digital capabilities and data to be able to understand the resources and where they're spent, as well as the outcomes of these services delivered to patients.
Excellent. I've been told I've got 30 seconds, but what you're doing there is talking about rewarding the sorts of living with systems that Dr. Al-Kharidi was talking about earlier. Do you have a very quick last word, either Dr. Al-Kharidi or Dr. Al-Fada? Very quick.
I think, as my colleagues mentioned, we need really to invest on data and to utilize the data properly, because this is the only way we could go efficiently in any preventive programs. For example, the idea of nutrition and diet, not everybody would respond similarly to any type of food. So what exactly determines the response rate or the response or the outcome of any intervention we're looking towards is really mainly on data, and the data mean clinical data, demographics data, omics data, genomics data, and everything related to the biology of an individual. And the second quick point is that we need to be innovative, and I think this is depend on really each society. For example, I think in Kingdom of Saudi Arabia, volunteering is a big thing that we could invest on, especially that we are having an ambitious plan to increase the Hajj, the pilgrimage, and the Umrah here, and most of the people are linked towards having high value related to the religious aspect of Hajj and Umrah. So investing in having an open platform for volunteering for elderly people mainly would increase their activity, would increase their value that they are contributing to society, and also would help in getting even more to the economy. So going with innovation in each society is a very important aspect.
I think that's a terrific note to end on. We've run out of time, but I think it's a good segue to the next session too. So thank you all, and if you want more, please delve into the roadmap, because there's a lot more in there than we were able to touch on. Thank you all.
Thank you.
Thank you.